Assalamu alaikum. Welcome to Parenting Hour. You're tuned in to Unity FM 93.5. And welcome also to our Luton listeners who are tuned in on 105.1. This evening we're going to be talking about a topic that I think most families are already aware of. If not, they should be aware of it. Who is their health visitor and what does health visiting mean? And what can it do for you? So if you've got questions that you would like to pose to our two guest health visitors today, please ring in on 0121 772 8892 and we can pass over those messages to them. Or you can also email studio@unityfm.net. And if we have an email from you or any personal questions, our two health visitors will be eager and keen to respond to you as quickly as possible. So health visiting is something that we do know a bit about. We know that we go to see the doctor when we're pregnant and the midwife gets involved and then we have a health visitor. But often people get confused in what order or what exactly does the health visitor do. So why we wanted to dedicate this program today to health visiting was to clarify to people exactly what you do and what is health visiting and how we can support our parents that are listening to this program, because health visitors play a vital role, and if you don't know your health visitor, you need to get to know your health visitor, and that is one of the messages we want to get across today. In front of me, mashallah, I have two lovely health visitors here that are going to explain all of that and all the questions that you have, explain about the amount of health visitors we have in the UK, which they were just telling me is reached now 10,600, which is a huge number, which is, alhamdulillah, is really good, because we do need to have people expertise to look after women after giving birth as well as newborn child. And they're going to explain it a little bit more and better than I can do it. So let me introduce Alice first. Welcome, Alice. Assalamu alaikum. Welcome to Unity FM. Thank you for being here on the show. That's really good of you and kind of you to come on the show.
Thank you for inviting me.
Brilliant. And also beside us we have Zareeda, mashallah, who is also a health visitor. Welcome, Zareeda. Assalamu alaikum.
Assalamu alaikum. Thank you.
You're welcome. It's lovely having you on the show. Maybe you could introduce yourselves a little bit and what do you do?
My name is Alice and I'm team leader for health visitors in central part of Birmingham, and we're a team that cover a large area and we have a caseload of children about 4,200. A bit about myself: I'm a paediatric nurse from background and I did my health visiting training in 2010 and qualified as a health visitor in during the last term of 2010.
Hello listeners, I'm Zareeda Riaz. I'm one of the health visitors and community practice teachers at Greet Health Centre. I've been working there for nearly over 3 years now. I've been doing health visiting since 2003. Like Alice, I was also a children's nurse, a paediatric nurse at the Children's Hospital. I worked there for about 5 years, and then sort of health visiting inspired me and I went into health visiting, did the training, and I've been doing it for so long now. And I'm also a community practice teacher, so therefore I teach other staff nurses to become health visitors, and I work within the community of Sparkhill. Enjoy my job really well, and I'm also one of the staff governors for the Birmingham Community Healthcare Trust, and keep myself busy as well with being a perinatal mental health champion.
MashaAllah. That's a lot of things that you do, mashallah.
It keeps me busy.
I bet you it does, mashallah, keep you very, very busy. It's interesting how both of you have come from nursing fields, and I must say a lot of my friends who've also been a nurse like myself, and to something that I thought of also at one stage of going into health visiting. Go into health visiting. I think it's lovely going through that process where you have, I trained as a nurse and a midwife, and I know when my children were growing up, I thought, yes, health visiting looks appealing as well, but I'm sure it's a lot of hard work. It looks nice, but it's a lot of hard work. So you can tell us a little bit about kind of your hard work. What does a typical day look like for you both?
For myself, it starts off with your emails at 8:30 in the morning, then I've got a team of 26 which I manage. So yes, we just go through the duty rotas, any sickness absence. We go through any paperwork that needs to be completed, finalised. If there's any meetings, I attend a lot of meetings and events. So that's my typical day. I also have lots of one-to-ones with my staff on the Need Be service. So that's a typical day for a team leader, for a health visitor.
Well, for myself, as a health visitor and practice teacher, my one day is actually the same. Like, for example, tomorrow I will have, in the morning, I will have a clinic. After clinic, straight, I will go down to do 2 visits. I've got a child that I'm going to see who's faltering weight, so I need to go and review his weight. And then I might go on to do a new birth visit, after which I might have to go and supervise one of my students, maybe do a one-to-one with her. Sometimes I also take students out to visits as well, because they need to know the clinical side of things as well. And I've also sort of booked staff members to do their clinical round as well. So although they are qualified, they have their yearly reviews to sort of re-observe them to see if they're doing their job as they should be doing. So it's generally a very packed week. And then sometimes, because I'm the staff governor for the trust as well, what I will do is I'll have like a meeting, perhaps from the Board of Governors meeting I had like last week, which was from 4 till 7. Now that time is my voluntary time. I don't get paid for that, but those are the kind of things that I do on a daily basis, weekly basis, I suppose.
Yeah, so your days are really packed, really, I must say, mashallah. So it's lovely that you're able to get some clinical time in there, which I'm sure is great and gives you the motivation to continue, because you can see the results, you can see and track people through and see how wonderful things turn out at the end. Whereas probably harder for you, Alice, that you're going to all these meetings and trying to arrange rosters and rotas and get people in. But that has to be done as well.
That has to be done as well.
Yeah, otherwise
the systems need to be in place. Yes.
So on a daily basis, would you kind of have to update systems as to what babies have been born and who's going to see what? Is that part of your responsibility as well, allocating families to people?
We have allocations once a week. We usually have them on a Wednesday, and we gather, there's a lead for each allocation. So every new birth visit, you would have a lead and antenatal contact, which we've recently started. Developments, any families with additional concerns or needs, and we bring that into allocations, and that's allocated on a weekly basis. So,
good.
Yeah.
So that's so already you're meeting the people, our mothers antenatally, which is wonderful. This is superb.
We see mothers between 28 to 34 weeks. That's a way of introducing the health visiting service. Sort of making that introduction with the the family, so that we're not a stranger when we go out to do the new birth visit as well. And if sometimes it's quite beneficial that you can just tease out certain issues that mum might be having, because she's got a bit more time to talk to us, rather than, whereas if it was a GP or midwife appointment, they have their own different sort of clinical things that they have to do, but and also time is limited, so that done, parents are still left maybe with some questions that they need answering. So that's a good way of mothers to talk, say for example about breastfeeding, if they're feeling low, etc., whether how they got on with their other children, the older children, or if it's a new time mum, then there's probably more questions that she's got. So it's antenatal, I think, is very beneficial. It's continuity of care as well. We'll see them at the new birth between 10 and 14 days. The child will also be seen again at 6 to 8 weeks.
Brilliant. It sounds like this, and I'd like to go into that a little bit more, but maybe before I just go into that, and I know I've jumped ahead a little bit with our listeners and go into in what you do and working wise. You were telling me there before we started the show that you were motivated by coming into this by your own health visitor. So maybe some listeners might be interested in hearing your story before we talk about exactly what you do.
Yeah. I actually was a mother at the age of 18. I was very young.
Very young mother.
I was a very young
Zareeda.
mother. I wasn't. I had an arranged marriage and I had my son at the age of 18. I hadn't been to college, so when my son was born, I had little knowledge of anything. So my health visitor used to come in, and there was times when I used to be actually in tears, sort of really struggling with breastfeeding and thinking that, oh my goodness, am I actually doing the right thing by him? Is he putting weight on, etc. So when my health visitor used to come in, she used to say, oh my goodness, you've done a grand job, you've actually you're breastfeeding so well because he's putting weight on, etc. So that used to give me a sort of a boost, really. And then there I was when I always had the interest of working with children right from when I was at school. So when I went to the careers advisor after my son was about a year old, I asked what I could do to work as a nursery nurse or something, and the careers advisor said, how about nursing? Have you ever tried nursing? I said, oh, am I able to do that? And so he said, yes, of course, with your GCSEs you can go on to do an access course. So I did an access course into further education and got myself a place at university. Now, the tricky thing was that my daughter was born in March, and I had the university placement to do nursing in September.
That was very quick.
Yes, and so I said to the university, could you please hold the space for me, because I'd like to breastfeed my little daughter until she's about a year old. And back then it was a great way that the university actually said that, yes, we'll hold the place for you for the following year. So there I was with two children. One was 3 and one was about a year and a half, and I did my nursing for 3 years. I went to do paediatric nursing. But I do recommend, it was hard work, but I do recommend to the youngsters of these days is to do that kind of thing before you have a family. Because although it's doable after having family, it's sort of that sort of quite inspired me to my own health visitor for my son inspired me to get into health visiting much later on after I've done my children's nursing. So
that's a great story indeed of how your health visitor is actually a role model, and how it's not just looking after you or looking after the mum and babies, but she's going out there as role models, and probably something you don't often think of when you're visiting, that actually you're motivating people to continue in their lives. And
she actually used to brighten my day up, and I had a rough patch, and at the time I didn't know the way I was feeling, etc., and I did keep a log. But when I look back on that log and the experience I got with mothers and my nursing and everything, I sort of look back and I think, yes, I think I had postnatal depression, and that's one of the things that we help mothers with a lot in our role as health visitors. Yeah.
And how inspirational you are as health visitors, and we're doing quite a few series at the moment from different fields of people inspiring others, and here is another continuation of that story, which is wonderful, of inspiring the young people, inshallah, to do something extra with their lives. I'm not saying parenting is superb, as you know, listeners. We say that's the best job you're ever going to do in your life, but here giving back again and training up, which you managed with 2 very young children. Alhamdulillah, you had family support, I assume, in that, mashallah, which was wonderful to allow you to gain your education and continue on your path. And that is something we're privileged to have in the UK, actually, that we have a system here that you can actually go into adult education and become a qualified nurse, midwife, health visitor at different stages in your life. You don't have to do this in the early stage of your career. You can do it later on, but as you were saying, maybe it's easier if you did it without children.
Well, definitely anybody can, but you see, I didn't stop, I just carried on, and I think when you've got the motivation, it's definitely worth pursuing any sort of aspirations that you have. Because I think one of the other things that sort of inspires me is also to actually reach out to mothers and sort of say that we as women, we are able to do a lot more than we give ourselves credit for, really. Yeah, definitely.
Yeah, definitely. We're good at multitasking and doing a lot. And I just look at some of the things that you do, Alice. I'm sure when you sit down and open that computer at 8:30 in the morning time, you have done a day's work at home before you've done that.
Yes, yes, it does start off early, and sometimes it is expected to work. You are expected to work during the weekends, but it's challenging. But it's really, it keeps you going. So I started I did my nursing to become a health visitor. So yeah,
you were very knew what you were doing.
Yeah, so I was quite passionate about public health and health prevention. So I did my nursing to come into health visiting. So. So that's what inspired me into coming into health visiting. I also was a volunteer for a children's centre before I did my nursing. So I think that also played a hand in.
And did you have to do a lot of clinical experience to go into your managerial role that you're in now?
I did. I had 3 years experience. And then I worked in a specialist role for a while. Okay. And then after working in that specialist role, I applied for my management role, and I was given the chance. So,
well done, well done. And the same as Zareeda with you for practice as a practice teacher. I mean, that's a really, mashallah, well done for being in that role and teaching others. Did you have to have a lot of clinical experience?
Yes, because you do your nurse. You have to be a qualified nurse to become a health visitor.
Yeah.
And for health visiting, it was another year to go back to university. Whereas it wasn't full-time university. You actually do practical and then also days at university. And then during my health visiting career, I sort of mentored students, sort of nursing students. So that built up my experience in mentoring and sort of supervision, etc. And then for the practice teacher course, I had to apply for that and go back to university again. So that was another year's course. So I've done I've also done like a health promotion degree, a nursing degree, and then now it's postgraduate level with the health visiting and also the practice teacher course. So after 1 year's training, you have 1 year's preceptorship, and then after that, you're fully qualified as a community practice teacher.
MashaAllah. So I think our listeners can really understand the amount of dedication you both have and the amount of study and the work that goes into health visitors. All of you really, and I rise up my hands to you all, mashallah, that it's not, you're just not qualified one day and that's it. There's many years and years of experience and learning and knowledge and skills. So when the health visitor comes to a family, you're coming with all of that knowledge and skills, mashallah. Brilliant. So that puts us into a good framework for our families and our listeners to understand why it's important for us to be talking about this today and engaging with health visitors more. You were mentioning there a few minutes ago about talking to and working with mothers that were pregnant. Now that is right up our street, in that we deliver courses to pregnant mothers as well as after delivery, our pregnancy tree course. So we try to get in there early to start with the bonding and attachment, which is so important that parents don't often think about, or mums don't often think about, and it should be parents, mums and dads in there, in bonding with their baby and trying to form that attachment right from the start in the early stages. Do you help them with that also, or are you more looking after the labour and preparing them for labour and preparing them for things that may happen down the stage?
No, definitely. We do talk about the attachment. That's on one of our top priorities, really.
Right, yeah.
For the antenatal visit, we use promotional guides that actually are the prompts to talk about the attachment between mum, and not just mum and the baby, but the wider family as well. Especially we try to incorporate fathers as well, and if there's extended members as well, we sort of have that chat with them, and sort of like, for example, at the new birth visit, we give out the children's book start packs, and that's one of the sort of good sort of talking points to get them talking about.
This the red book you're talking about? No.
It's like actually at the new birth visit we give the book start packs where we talk about how important it is for the mother or the father to read to their child.
Oh,
so,
okay.
Yeah, so there's like a book start pack that they
Start,
because
yeah.
babies from birth can see patterns like black and white, and the more that they're exposed to, it can be prayers in their own language. It can be stories in their own language, etc. As long as they're talking, even during pregnancy, when the mothers are pregnant and they're reading to soothing sounds, etc. That's all to do with the attachment. It's so important for the upbringing of that child, really.
Yeah, it is. It's amazing how really we link so much back to that attachment in the early years and building that bond even for later on in life. And we're so happy that we're going to have you coming along as one of our trainers, inshallah, very soon to understand our program and how that can be incorporated more into what you already do. And it sounds like you're already doing a lot, so I don't know how you're going to squeeze in this as well, but we will we'll work around that, inshallah, also, and the importance of this. So because I think a lot of new mums, they know the importance of, yes, it's good to have the baby there and talk to the baby, but don't really understand the brain development at that stage and what goes on behind the scenes. So that's good that you already explained that to parents. And what else do you do then if we walk through through the pregnancy? So you have your first visit, which is 28 to 34 weeks. Then when do you next see the
at the primary, what's called the new birth primary visit, we're sort of mandated to do that at between 10 to 14 days. So it can be alongside the midwife. The midwife also visits at that stage as well, but sometimes the midwives discharge the mother by then. Other times, if the child has sort of certain ailments like jaundice, etc., the midwife will stop, will continue come. She may be sort of monitoring his weight, that he hasn't gone back to the birth weight, etc. But we'll go in from the 10th to 14th day, and we've got standard operating procedures that we follow as per new birth visit. So there's a lot to it sort of entails for about sort of roughly an hour's visit, and we do cover a lot. We'll sort of go through the Red Book with the mum, the importance of the Red Book, the development. We'll explain about what the health visitors do, what our role would be. So basically the child is under our remit from birth to 5 years old, and we work closely with roughly, I think within our health centre we cover about 12 doctors, so we've got a quite a big caseload, and all babies that are delivered we go and visit. After that we would see the child at 6 to 8 weeks, but if before that, if the child's struggling with their weight, if the baby's struggling with the weight, or mum's struggling with breastfeeding, or any concerns that she's got, if she's feeling low in mood, then we'll visit them more often. Like for example, I've had a mother who actually had sort of quite low mood, on the verge of having postnatal depression, so I offered her like 6 listening visits. So in those visits, if before the 6 visits she's sort of her mood's got better, she's feeling a lot better, she will lead the way, and she will actually say that she's feeling a lot better, she doesn't want me to come, etc. But on the other hand, if there was a mother that was actually deteriorating, not getting any better, then we would make the appropriate referrals. So we do catch things quite early on,
which is really good.
There was a case that I had whereby the little baby wasn't thriving. The actual father was a doctor. It was mum's second baby, and I actually wasn't happy the way the baby was thriving. He was sleepy, etc. So I actually referred him to the hospital to say that I've asked the parents to maybe, even if the hospital checked him out and everything was fine, at least I would be reassured.
To reassure, yeah.
Yeah, but what actually happened was when the child was seen by the hospital, they picked up some heart concerns and was transferred to the children's hospital. So those kind of things, the rare cases, but we because we're sort of qualified nurses, we're able to pick
pick up these things.
easy,
Yeah. And sometimes, busy parents, they think that this is normal. A newborn baby especially, think, oh, this is a nice quiet baby I have, and a sleepy baby, and just take it like that, and don't think that there might be something else, or don't think there's a problem. So as professionals, we all probably don't think it happens to our own children either. So that's really good, mashallah, that you pick up things like that. And I'm sure you've picked up, Alice, a lot of things also in your training. And
yes, when I do visits.
And your visits, I meant.
Yes, when we're short-staffed or when it's the holiday period. So I do go out. And research shows that the early days are crucial, 1001 days. So that's why we start off antenatally. Those are usually done at home. And as Zareeda said, we do the new birth visit. After the 6 to 8 week check, we see the families again. We have open door clinics, so parents can come in or they can book into clinics and come and see us. And then we invite them to see us at 1 year development and 2 year development, because it's quite crucial for the child to have their development checks and see if they're developing up to the national standards. We use a tool for that. It's called the Ages and Stages. And
wow, that sounds interesting, and I'm actually going to get you to explain a little bit more about that and come back to that after this commercial break. So listeners, if you want to know what Ages and Stages is all about, which sounds really interesting, do tune in to us after this, inshallah. Assalamu alaikum, welcome back to Parenting Hour. You're tuned in to Unity FM 93.5, and I'm here with you for the next half an hour. We're here talking about health visiting with our two experts, mashallah. We're very privileged to have Alice and Zareeda in the studio with us, talking about health visiting, their experience, their training, and what they do. And just before break, we stopped with Ages and Stages. It sounded very nice, Ages and Stages, of what you were going to explain to us. What is Ages and Stages, and what kind of a tool this is, and why you do this with parents?
Yes, Ages and Stages, we predominantly we carry out, it's a tool used to assess the development at 1 year and between 2 and 2.5 years old. But they can actually, the actual questionnaire can be done before those periods. It's not specific that it has to be exactly on those birth dates. And what it actually assesses, it's a list of questions that is asked, the parents actually answer. Ideally, it would be useful if the parents sort of completed the questionnaire before they come to this session, but sometimes due to language barriers, etc., the questions are actually filled while they're in clinic, so we can give them assistance with that. And what it actually covers is it's a breakdown of various different types of questions that actually teases out sort of the child's development to do with problem solving, speech and language, the gross motor skills, their fine motor skills, and also with their hearing and vision, just to see what stage they're at. And then once we collect the scores, we can sort of explain to parents what stage their child's at. Like, for example, I could get a child that actually, there's like shaded areas on the score sheet that if a child, like a 1 year old, wasn't performing up to their ability and they had more so in the dark shaded, the scores were below, quite sort of low in the dark shaded area, then we would refer them on to like a paediatrician to be assessed. Sometimes we have 2.5 year olds that will actually score poorly, and they would be referred for conditions like autism, etc. So they're picked up quite early.
And it's really good to get parents aware of this, and even the fact that you're asking them these questions to make them more aware of what is fine motor skills and how can they help their children to develop that, maybe using tweezers to pick up a piece of paper or from one thing to another to develop their skills.
And it may be that the child is actually scoring really high for all the others, and it may be just one factor that they're quite, because maybe that they haven't had stimulation. So, for example, they're scoring really high on all the others, and with like speech and language therapy, like they may need therapy because they haven't actually been exposed to. So, and even if it's not necessarily a referral to therapy, but we can see them again, give them the tips, the fact sheets, etc., for parents to work on, and we review them again in 3 months' time, and we see a great improvement.
Great, great. And it's really good. It's all getting in there early, isn't it, to prevent problems down the line, to be helping parents. Very good. Thank you for explaining that. So it's a nice title to what is a very good and structured process to help parents with their children and preventing problems and picking up problems. Great. And then there is something that you wanted to explain to us, Alison, about sleeping safe or safe sleeping.
It's National Safe Sleep Week from last week. So it's reducing the risk of cot death. There's been a lot of incidences where children are not put into the cot in the correct position, or they have lots of toys in there, or they use a cushion, or they're overlaid. So especially for our communities, for where we work in, it's very important to have a room temperature, monitor the room temperature, and also not have someone smoke within the area that child is. So because that increases the risk of cot death.
We've just recently done a programme about smoking, actually, and even passive smoking and how children are affected by that. So that's really good that you're linking that in. I'm sure listeners will have that in their mind still.
Yes, because research just show that if a parent was to be smoking, they would need to come back in, if they were going to go out and smoke, come back in and have a shower and change their clothes before they would pick that. So, so it is... parents just need to be mindful, and then you have extended families and you have relatives who come in. So it's just raising awareness with safe sleeping. We will be going out health visitors, so if you do have a baby in the next few months, health visitors will be going out, and either at the antenatal visit or the new birth visit, we'll be giving out packs about safe sleeping and what parents can do to reduce the risk. There's also elements of co-sleeping, and we don't usually recommend, especially if you're not breastfeeding or if you're on any medication, not to co-sleep with your baby and use a Moses basket or a cot and have them sleep with their feet touching the bottom and one blanket and monitor the temperature, and no hats and gloves in the house.
I love the way you say their feet touching the bottom, because that's something new that I see my daughter doing with her children that wasn't in when I had children. And when she first doing this, I was saying, why is the baby so far down? And then she was able to explain to me about that, which we all need education about. Things change, and what's the best policies to help our children, our grandchildren in that respect. So that's really good that the baby must be down,
the feet touching the bottom of the cot or the Moses basket, and the sleeping face up. It's not about scaring parents, because all parents attempt to do the best they can, but it's providing to them the latest research and what they can do
and sometimes
to reduce the risk.
The blankets, they need to be appropriate blankets, sort of, ideally I would say those that are 100% cotton, because a lot of the fleecy blankets that are on the market these days, they warm the child up really quickly.
Too much. So be aware of that, and actually I suppose parents need to be aware of these sleeping bags that they can zip up and they come in different thicknesses as well, and some are quite heavy. And if that's zipped up around you could easily overheat in there.
And it restricts the child's movements as well.
Because babies, they don't feel the same heat. The cold, like we may be cold, but that not necessarily doesn't mean that the baby's cold as well.
And do you have a problem with cultures around that? Because I know when I used to take my babies when they were young abroad to different cultures, and they would think, oh, they're freezing cold, and I was saying, no, they're warm enough, because that culture was wrapping them up and putting blankets on. So do you have to come across the same things here with different cultures, different understanding?
So, you find some cultures they will actually won't take the baby out at all, saying that with the fear of the child catching a cold, etc. And even inside the house they would actually put extra layers on, etc., because they think the baby's colder than they feel. Although yet themselves, they're actually, if a mother's actually sitting in the living room and she's only got one layer of clothing, and then the baby's in the cot with about 3 layers, that's not sort of recommended, really.
And by touching the baby's hand doesn't give an indication of how warm or hot they are. So what was the recommendations?
When the baby's cold, they will let you know that they're cold. But when they are hot or warm, they do tend to go into a deeper sleep. So if they're cold, they will cry and they will let you know that they're cold. Yeah.
So
That's
parents will be worried.
They will know. Parents will know that my baby's cold. Yeah.
So it is the advice is not to overheat.
And the risk of smoking. So
smoking, I suppose it covers the electronic cigarettes as well, and also it's still developing, but there's new research to sort of say about I think some cultures use the bahur incense. That there's electrical devices and there's also the other ones as well, but that could actually create a lot of like a smoky atmosphere
if you're using it a lot. I suppose,
if you're using it a lot. Sometimes general just use is okay, but we've seen that we've been to some families' homes where it actually appears as if there were lots of people smoking in there.
Really?
Because it's so smoky. And that's not good for the baby. Or even, other young children as well.
It limits the amount of oxygen that the babies can breathe in.
Of course, when you think of it like that, and some parents need to be aware of that. And you mentioned there the electronic cigarettes. Are we still waiting for research from that? Or do we have some research? What is that okay to smoke with those in the house?
No, because they're exactly sort of probably more so with the as it is smoking. That's smoking.
Because they still contain nicotine and all other harmful chemicals.
So the advice is whether you're smoking cigarettes or the electronic cigarettes, to do it outside. And as you mentioned, Alice, to actually the real recommendation is to have a shower afterwards, because it does stick into your clothes. And I know that from experience. I was mentioned to the doctor that came on recently talking to us about smoking, that when my child was young, I gave a loan of the travel basket of travelling cot to some friends who I didn't realise were smokers. And when I had it back and put my own child into it when we did travel months later, I thought everything was gone and it was aired and everything. She got sick straight away when I just placed her in it, and it's only when I put down my head to pick her up that I felt I got the whiff of smoking there that she wasn't used to. So the smoking does touch to the particles of our clothes and to fabric cots like that. In those days it was fabric cots, so to be aware of that.
Definitely,
and we want the best for our children. So we've talked a lot about the benefits of having you here with looking after our families. Can you kind of give us a couple of examples of you and working with your families and things that you picked up? And maybe these are more unusual examples, because I'm sure every day you're working and picking up lots of things, but if you've got some kind of different examples of situations that has turned out very positive or positive ending because of your interference or interventions, not interference but interventions, and positive thinking and being able to identify things, and it had a positive outcome rather than what was sliding down to a negative outcome.
I suppose we have lots of, we have different various scenarios every day, but I think generally there's those just general development issues with children, that sometimes parents can't, sort of, probably won't think that, because if they haven't been exposed to other children of their same age as that child, they won't know any different. So, I mean, we've had cases where we've referred children who have had like autism, and with the right, or even like speech and language delay, and so with the right referrals and packages in place, they've actually improved. Graded.
When you're talking about autism, can you remember a case maybe that you did pick up that, because that's actually really great that you're able to pick up this at so young, 2.5, that you can actually pick up a child that is displaying some autistic traits. Can you explain a bit more about that, about a child that you did pick up to?
Yeah, basically the mother had other children as well, and this young little boy was actually seen, and mum's, when she came to clinic, she just said, there is certain behaviours that he displays that she thinks that he will just grow out of. And so when I sort of probed into that further, and I said, what sort of behaviours? And so she explained that he would actually sit there rocking, etc. And so I made an appointment to go and see the child at home. And when I actually went to see him at home, he was he wasn't fully aware that I was actually there. So when I spoke to him and tried to draw his attention, he didn't acknowledge me at all. Whereas children of his age would normally acknowledge a stranger coming into the house. You know, so it appeared as if that little boy was in a world of his own. And then when I sort of discussed further, there's other, you know, sort of little tiny behaviours that Mum sort of teased out. She would say that yes, he would do like he would put things in a line, and so he and also scream at a loud pitch. So she found it difficult as to what he wanted. Sometimes that he wouldn't be able to communicate to her what he wanted. So he may be hungry, or he may be wanted to go to the toilet, etc. But instead of sort of verbalizing that, he would just scream. So there was very limited language at the age of, I think he was, from what I can recall, he was over 2.5, so didn't have any words at all. So upon referral, Mum was really grateful that when he was seen by the paediatrician, that they actually, although there was all that anxiety and stress associated with their child being diagnosed with autism, it was, in a way, when Mum had a chat to me afterwards, it was a relief for her. It got picked up, and you know that she knew what it was. So they had lots more information. They went to the autism group, etc., where there was other parents who had similar cases. And so she got to feel a bit, you know, more comfortable with the way the child was. And
probably able to put in techniques and things, processes in place to help him and help her.
Help him, yes.
Yeah, which was really good indeed. And it doesn't mean that all our listeners that are listening to the radio that have a child that cries with a high-pitched cry or rocks a bit, that they're, of course, on the autism trait. But what we're saying here, listeners, is that, you know, if you're worried, do contact your health visitor, and they will come and do an assessment there and then reassure you and give you the right direction to go or make the referrals.
And other things that we would actually pick up is also, like I mentioned before, with mothers having low mood, but what we do pick up is mothers that have postnatal depression. One of the cases that I had was that Mum was, her child, I'd seen the new birth and I'd seen the child at 6 to 8 weeks. Mum didn't display anything until she was she took one of the older children to hospital, and the consultant had some concerns with regards to how she was behaving, so he actually phoned me up and said that maybe the mother needs extra support. So when I went round to the house, the father actually disclosed that she felt like this before. So yeah, when I visited a mother who had postnatal depression, I didn't have the previous history, but when I went in and had a chat with the family, the father explained that there was similar sort of signs that he'd seen when Mum had the other baby, but they weren't as extreme as how Mum was at the time. So when I spoke to the mum, she was in a very low place, really. She didn't want any contact with the children at all. She didn't want to be near them. There were certain behaviours that she was displaying, that, and she was in a flood of tears, etc. So I knew at that time that Mum needed extra support and help. So we referred her on to practice,
cognitive behaviour therapy practice, was as a counsellor.
To the GP's practice, and who in referred her further. And then, although Mum was breastfeeding, she wasn't able to have certain medication, but the doctor made sure that he gave her certain medication that she could actually carry on breastfeeding.
Wonderful.
So they didn't take her in as an inpatient or anything. They kept the mother and baby together. So with family support and the right medication, 6 months down the line, she felt a lot better.
Brilliant. And you can see that's a more severe case than what we normally come across. But there is treatment there. Getting in early again, you have that relationship.
We have like the mother and baby units at the hospital.
If there is a need.
If there's a need, or if they're picked up earlier during pregnancy or soon after at labour, on the labour ward.
So the idea is getting in early, having the services there that are available, having the GP able to put on the correct medication. So mashallah that she was able to continue breastfeeding, that's wonderful. Whereas maybe years ago it would have been this or this, but nowadays with the right support around, everything can be mashallah worked out for the best of the baby and the mum.
It's about the families recognising when the support is you, and recognising that the mother might need additional services. So if a mom does display she's not sleeping well, she's just given birth, she's not sleeping well, she's not eating well, she's not her usual self, she's not getting out and about, bonding and attachment with baby isn't what it should be, then families, especially extended families, do need to get in contact with the GP to get mom some help. It is a bit of a taboo subject in some cultures, but if we all work at it, we'll.
And I think we need to talk about it to change that taboo. You know, mental health. If we had cut ourselves or broke our arm, we go and see somebody about it, we do something about it. But it's the same mental health. We need to look after ourselves, and this time after having a baby, we do know the body goes through different changes, and we need to be aware of that. So it's great that you're aware of these things and able to pick them up early. So it's not just the babies that you're focusing on, it's also the mums, and I'm sure the dads as well. Probably when you go visit as well, you talk to the dads and see is there any depression that dads might be facing.
Yeah, definitely. I mean, we have at the local children's centre, we have fathers groups. They do them on one of our health visitors is a male health visitor, and he started a group on a Wednesday evening, and that's like in his own time. And then there's also, I'm sure that the children's centres, they also do like a Saturday daytime sessions as well for fathers as well. So there's lots out there for people to gain further knowledge.
We also work with other agencies. So in Birmingham we use the right service, right time model, and if there are families we identify need additional support, we can get other agencies. So health visitors are placed quite uniquely where they can access those services and start a family FCAF, which is just a common assessment framework, but brings all the agencies together around the family and brings the support together. So it could be housing, immigration, it could be low mood, it could be other additional. So if you've got more than one or more needs, we can get that support in place.
Wonderful. So you do much more than what people really think. You mentioned something very interesting there about your male health visitor. Is there many male health visitors?
We have got a handful.
We've got in Birmingham Community Healthcare, I think we would probably have about five. I've got one in my team.
And we've got one in our team. There's one also in the Aston team, and I think Yardley.
And how are they accepted in the community, going to see families, going out to see newborn mums? Are the mums aware it's a male health visitor coming in?
Yes, they do call in and they are made aware, and it is a sensitive visit. But out of, from the past 2 years, I can only recall twice when they've requested a female health visitor. Parents do have that choice, and if my male health visitor does call in and they would prefer a female, then we can organise that as well. But he's quite welcomed actually, and they really do enjoy it. It's probably the diversity. So
very good. And of course, as health visitors, you're not doing physical examinations of the mother,
No.
so there's no need to be worried about a male health visitor more than any other male doctor, because they will not be doing the physical touching. It's just the parent probably would like to know if there's a male coming in, and does he come on his own, or does families ask for another female?
If there's no language support required, then it will be by himself, unless they request someone else. They can have another health visitor.
And which gets me thinking also, as professionals, you're going out to houses alone, you're working as individuals, alone practice. How do you manage that, not knowing what's behind the door or who's behind the door? Have you ever felt worried for yourselves, being health visitors?
We have a lone workers policy that the trust has issued us with, and we do follow that. And then we have in-house strategies. We have mobile phones. We let each other know where we're going. But a lot of the visits are made in pairs, or we use interpreters. So a lot of the time, yes, for us within the team, I've not come across any issues, but we do have processes in place and policies to follow. So yes, we are aware where everyone is at each given time.
So, like, for example, we will go out to the visits and all the visits will be written down. And if we were to go home from the last visit, then we ring up and say that we were actually leaving this house and we're off home now. But if that person hasn't rang in, then the team will take further steps to actually find out.
Great, that's good. It's good to know that you're safe as
But
well.
predominantly, I mean, so far in the 10 years that I've never had an issue where I've felt sort of vulnerable.
Alhamdulillah.
Alhamdulillah.
Alhamdulillah. As we come towards the end of the show, and it's really interesting hearing about your work and your practices and what you do and getting to know more about health visiting, could you give our listeners any quick tips to help them with their children, or to help them with their newborn babies or with their children, as to things they mightn't have thought about that you have learned over the years? If you remember these things, this will help you.
So yeah, basically, I would actually say being a parent is an exciting time. Enjoy it. It's an enjoyable time as well. And if any concerns or worries, seek advice and help from. It can be anybody really, from your elders, from the community, but most of all, come and see your health visitor, because we're always there from Monday till Friday, 9 till 5. Yeah.
So they know where to contact and who to contact.
Yeah.
And the Red Book is full of resources, and it's constantly changing. So I would recommend have a flick through your Red Book. And health visitors at Birmingham Community Healthcare have also got an app if you want to download it. Just type in health visiting at Birmingham Community Healthcare and you'll get an app, and it will just give you some advice. There's key events and there's lots of other things you can go through. It was developed by one of our team leaders, and there's lots of other resources. There's the Birth to Fife, which you can get online by the Department of Health, which I would really recommend. We used to give hard copies, but because of cuts, they've been here. So, but a tip for parents: just be yourselves. You know your child well, and just go with it. If you feel that you need extra support, you can just pop in to see a health visitor, or you can always pop into the children's centres as well. But just enjoy the moment.
Stay healthy and keep your family healthy.
Brilliant. That's a lovely ending to have. And of course, if anybody would like to contact you via us by email, please do email in studio@unityfm.net and we'll pass on the emails to you. Or if they want to phone in with a message or a question, we will pass on the questions to you, and I'm sure you have no problem in answering those. Thank you so much. It was wonderful speaking to you. You're welcome. Thank you indeed. I'm sure there'll be a lot of very interested comments after this show, and people will know what health visiting is all about. And what we're trying to do is make people aware of the importance of the work you do. And thank you so much for coming on and showing us that.
We would also like to come back and be invited to do a talk on burns, because it has been some research by the Children's Hospital has identified that there's a high rate of burns within the central Birmingham area. So we would like to come in again.
Definitely. We need to do a whole show on that, on burns, to help parents to prevent. So it's a high instance. Okay, we'll come back to that again another day, definitely, because we do need to educate our parents about that, and it's a very important topic. So look forward to talking to you again soon. Thank you, listeners. Have a good week, inshallah. Assalamu alaikum.